Hello, everyone. Welcome to our Stop TB's focus group on AI-based imaging for TB webinar, the fourth webinar on experimenter implementer knowledge sharing on ultraportable X-ray and CAD. And today we have two projects in India. Both of them are, they have experience using this Fuji X-ray equipment as a pilot project, which is funded by the TB Reach initiative of Stop TB Partnership. And we are also honored to have three welcome speech from the head of TB Reach of Stop TB, and the district and state TB officer from the implementing sites of the two projects in India. And followed by that, there will be the presentation itself, and during which you're more than welcome to post your question in the chat. We will collect them and raise the question at the end of the Q&A session. We'll have about 25 minutes to do so. If you do have a question you want to raise yourself, you can raise your hand during the Q&A session. And just for your information, this webinar will be recorded. So if you are unwilling to put your camera on for the recording, you can turn them off. The presentation and the recording will be made available on the Stop TB's website a couple of days after the webinar. So for those your colleagues that you know who cannot make it to the webinar today, feel free to share the recording and the slides with them. Finally, just wanted to let you know, we have designed a short feedback form. So if you're so kind to let us know at the end of the webinar, how would you like to see us improve? What are the other information you'd like to hear? Please fill that in. It won't take a long time. Now, with that being said, let's start our program today. And first of all, we're honored to have Dr. Jacob Creswell, who is the head of the TB Reach initiative at the Stop TB Partnership. The TB Reach initiative is a grant-making mechanism within Stop TB that is initially funded by the government of Canada, but now is also funded by UK Foreign Commonwealth and Development Office, the Gates Foundation, and the USAID. And the focus of TB Reach is to fund pilot innovative technology and innovative approach as pilot project to establish the evidence base for future donor to pick it up and scale up. So without further ado, let's welcome Dr. Jacob Creswell to say a few words. Jacob, the mic is yours.
Thank you, Jijen, and welcome everyone. I was going to talk a little bit about TB Reach, but Jijen did an excellent job doing that already. So I will just say that we are really excited to see this work in this area of interest take off. It is something that TB Reach has been focused on for a decade, and our funding mechanism really allows this kind of work to take place. So we're especially excited to hear two partners from India who will talk about their work, but really seeing this work take off globally. TB Reach takes a lot of risk. That's part of how we operate, and we are allowed to fund interventions that are not necessarily WHO approved, or they can be interventions that have been recommended, but may not have been implemented in specific countries or areas. But really, the artificial intelligence work that we've done, again, over the last 10 years or more, is an example of being able to take risks to work on an approach and see it to come to fruition and now in WHO guidance. We started looking at CAD4TB software version 1. Now CAD4TB is on version 7 in Zambia in 2013. And the TB Reach group in Zambia, CIDERS, was the first one to publish this, how it could work in an implementation setting. And the results were quite promising, promising enough that other countries, Bangladesh, Pakistan, Indonesia, applied and received TB Reach funding in wave 3 to do large-scale private sector work. And Bangladesh actually, ICDDRB in Bangladesh was the first group that published independent results of a TB Reach, of artificial intelligence evaluation. Projects in Nepal, Tanzania, Cameroon followed. And in 2016, WHO convened a group to review the data at the time, but decided there wasn't enough evidence to consider a recommendation. However, it really didn't stop the interest globally that was already building for artificial intelligence. And IRD in Pakistan was using this at a very large scale, screening hundreds of thousands of people. And a new software began, not just Delft. Delft was the CAD4TB was the first one. And now there are 17, I believe, work that Jigen has led with FIND to do a landscape analysis. But we reviewed three softwares in 2018. The first comparison across countries, across different types of patients and different types of software. And they all performed significantly better than human radiologists. And then as you well know, in 2021, WHO issued recommendations, global policy around the use of artificial intelligence based on data that FIND and StopTB had contributed and presented to the guideline group. And we really saw that there was even more of an interest with the CRM19 funding from Global Fund. And we're quite excited to continue leading this work. More publications and evaluations of multiple packages. A grantee in Vietnam recently published some work around evaluations of 12 different software algorithms. So there's a lot of work that is growing. The space will continue to evolve. It's very early, and we're excited to continue to support partners who are interested in and work with implementers to refine what they're doing. So welcome everyone, and really looking forward to the discussion. Thank you.
Thank you so much, Jacob. And all of these initiatives to seek innovation in technology, in approaches, it's important to have platforms like TB Reach, but it's also important to have the support of local authority. And today we have two speakers, Dr. Misra, he's on the call. He is the state TB officer for Bihar. He's responsible for the National TB Elimination Program for the entire states with a population of more than 120 million. For a very long time, Dr. Misra has been the nodule officer for drug-resistant TB care in the state of Bihar. In the past, he also has served on the WHO and has been keen interested in the community approach to health management. So Dr. Bihar, the floor is yours if you want to say a few words.
Thank you very much. So thank you, Jacob. You have already laid the platform set for the discussions. So I should not take much time, but what we realized that artificial intelligence-based tools, particularly in the radiology, is very much important in the resource-limited setups. So recently, India has conducted National Tuberculosis Prevalence Survey between 2019 and 21. So one of the finding was that because the 97% of the presumptive TB cases, or the not presumptive TB cases, 97% of the participants in the study were screened by X-ray. So then when the result came, almost 42% of the people, they did not have, those who were diagnosed finally having tuberculosis and microbiologically confirmed TB, they had no symptom at all. No symptom, no cough, no fever, no weight loss, nothing. So just because X-ray was done, and that is why they were the suspicion was that they should be tested for the rapid molecular test or other sputum microscopy this way. So the assumption was the similar earlier also. The only limited thing was the confidence in the how to interpret the radiological findings in resource limited conditions like Bihar. Our 19 districts are flood affected. So many of the hospitals, they do not have even the X-ray. So it's at the subdivisional level and the district level, but not all the primary health centers have X-ray. So then the digital X-rays started coming, and still because of the outsourced agencies. So when the digital X-ray is done, it is the report is sent to, say, Chandigarh or Delhi or some other place, and it takes time to get the report. So then I'm very much lucky that Surya Prakash and his team at Innovators in Health, they what they did in the Dalsing Sarai, it is not the district headquarters, it is the sub-district headquarters. It's a subdivisional, you can see the sub-district headquarters. And there they engaged with the radiological setups, and they used the cured tools through their system. They trained the public health doctors and also the private doctors, and it generated the confidence, and that way they started using it as a screening tool. And they tried also that whenever their X-ray is suggestive of having a TB, they did not believe the TB. So the patients were encouraged to submit the sample, and they were tested by the Curtis-based nucleic acid amplification test or the TrueNet, whatever is available there. So this is very much a breakthrough, and we are looking forward to use this platform more at a higher scale and very with the speed, because our state has 1,300 lakhs population. So it's a big state, and India is a big country. So escalating and expanding these technologies at the grassroots level, at the same time creating a confidence in the public health professionals and also the clinicians, because finally it is the role of the clinicians, they have to believe in the newer technology. So thank you very much for organizing such a nice discussion. I will be throughout the session, and will learn whatever I can, because this is a very nice thing. So we will replicate whatever Jacob was expecting us, and thank you. So you should start the more focused presentations and anything what you is in planning agenda. Thank you very much.
Thank you so much, Dr. Misra, for the continued support of Innovative Solutions in your state, where Innovator in-house implements. Let me introduce the third welcome speech speaker. She is instrumental in the second project from TB Alert in accepting and rolling out the innovation. And Dr. Rajswari, she's the district TB control officer in the Sangha Valley district. there's some noise. And she has been, under her leadership, she has enabled good testing and treatment outcome in this very hard to reach, but also highly vulnerable population in the industrial areas. Now, Dr. Rajeshwari.
Yeah, good evening. Hi, everybody. I'm Dr. Rajeshwari, working as District TB Control Officer of Sangareddy District of the state Telangana. I'm really happy and delighted to be a part of this global platform, and I wish to share my experience. So basically, our district comprises large number of medium and large scale industries, where we have population working in the industries from mostly migrated population we have. So, and most of them, they are skilled and semi-skilled workers there. So mostly they are like, because they work in the industry, they are exposed to they're having high risk factors, like because they're working in some chemical industries, they have some tobacco usage and all. So because of that, they are more exposed. And with the help of TB Alert India, we could organize almost 8 to 10 camps in this year. And we happened to screen around 620 people who are having symptoms suggestive of TB. And simultaneously, we tested by chest X-ray and by sputum examination. And out of 158 people who are found to be having X-ray suggestive of TB, and we tested them simultaneously by CBNet, and we found 155 cases were bacteriologically confirmed. That was like a huge thing, because the mobilizing people to come to the district hospital where we had this facility, it was not possible. So we conducted the camps where this skilled labor lived. So because they were very hesitant to come to the district, access the facility, because there was loss of wages, and education level also was a bit low. They could not really understand how the symptoms were leading to a disease, which later could be very fatal. So we reached out to them in the area where they were living, conducted the camps, and with the help of this digital X-ray, we could diagnose many cases and put them on treatment. And simultaneously, we educated how to continue with the treatment. And really, we are very thankful to the TB Association India and the team, so which was very helpful in timely diagnosing these people and putting them on treatment. Thank you. This is from my side. And next week also, we are having 2 camps. We are very much thankful to the entire team, because we could diagnose lot number of cases. As our country is going towards TB elimination, we were able to diagnose and pick up the cases early and put them on treatment. This is from my side, ma'am.
Thank you so much. And I thank you so much for all the speakers who gave us the welcome remark. And just before we go to the presentation, I see people are already taking the lead of introducing themselves in the chat. Feel free to do so. We will not go through the individual introduction, of course. And also, my name is Zhizhen Qin. I'm the Digital Health Specialist at Stop TB Partnership, and digital X-ray and AI is one of the areas of focus of our work. Now, without further ado, let's bring out the meat of the webinar today. So first of all, we'll have a presentation from Innovator in Health. And our speaker is Smriti Reddy. She has the a master degrees in from Johns Hopkins, and she has been leading the evaluation of the AI based X-ray solution for the Innovator in Health. She also has she was being trained as a doctor of dental surgery, and she worked extensively in global health research, advocacy, and program implementation with the focus of TB care. Smriti, are you ready?
Yeah, thank you, Zhizhen, for the introduction. I'll just share my screen. Is my screen visible?
It is visible, but we can also see your next slide. You're not presenting the whole full screen. Yes.
Okay. Is it better? Okay. So yeah, before starting, a very big thank you to Stop TB Partnership for giving us the platform and the opportunity to present our experience of implementing CAD AI and TB care in Bihar, India. This is the presentation outline. I'll be covering all these points over the next 15 to 20 minutes. So let me start with a brief background of the organization. Innovators in Health is a grassroots nonprofit. We have been working in Bihar, India since 2010 alongside the National TB program towards the common goal of TB elimination. Apart from other donor agencies, we have been supported by Stop TB Partnership for 4 different waves, including the current ongoing wave, wave 9. During our Wave 7 grant, we implemented an AI screening solution called QXR, which has been developed by Cure.ai. This was done in the period of July 2020 to May 2021. For the program, the vendor selection went on as we received a grant of 10,000 scans along with our TB Reach proposal. So there were no additional procurement costs. Just to make it clear, we didn't procure any kind of infrastructure or machines or X-ray units. We just received the software that has been developed by Cure.ai, and that software was deployed on our existing digital X-ray modality. And we used QXR. QXR is a chest X-ray screening solution that has been built using deep learning. Once the X-ray is analyzed, it's classified as TB positive, as a presumptive or TB negative. The software also identifies the abnormal findings, as you can see in the picture, and it highlights them on the X-ray. It's also written thoroughly in the report that comes with the X-ray. We selected this product because we had already seen a couple of research studies that had been published. It was clinically validated, and also it was being developed within the country. Like every other program that we start implementing, prior to implementation, we took permission from the state TB office. There was also buy-in from the district TB centers and physicians that were practicing at the primary health center in our program area. We involved all the program staff, including the community health workers, to understand where would be a proper place to integrate AI into our already ongoing community health worker driven program. And the most important engagement was with the digital X-ray centers. We had to understand these are private digital X-ray centers that we were working with. I'll elaborate it in the further slides. So we had to talk with them about what kind of infrastructure they have and what we will be doing and what they should expect during the deployment process. The training component of the whole tool was not very extensive because it was pretty easy to understand, but we had an introductory call with the technicians in the digital X-ray center prior to deployment. After the deployment, the program staff was trained on how to access the web portal and look at the results, and also follow through what is happening within the program. And other than that, the X-ray technicians were trained on how to operate the system. We engaged physicians in one-on-one conversation around what the solution is and how the reports do look like. So the site selection was done, as I already mentioned, we received this grant as a TB Reach Wave 7 with the TB Reach Wave 7 project. So within that project, there was a part of case finding within the public health sector, which was particularly driven by community health workers or ASHA workers. And we integrated the AI screening part within that algorithm. The AI solution was deployed across 4 digital access centers in Samastipur, Bihar. You can see the area that has been marked within the blue circle. These centers, so the whole district was divided into an implementation area and comparison area, and everyone who was in the implementation area and accessing and who was getting a digital access center was getting a digital X-ray was covered within these centers. And people with anyone with TB-like symptoms accessing care in the public health sector was screened by the AI solution. So looking at the screening algorithm, our screening, the algorithm starts from referral. The sources of referral could be community health workers, informal providers, or within the community health cell. There are certain groups that work, such as self-help groups that work within the community. All these sources can act as a referral. They refer anyone who has any kind of difficulty that is even remotely linked to tuberculosis. Once a patient is referred to the program, they are screened. Screening is done either by our frontline healthcare workers or the community health workers. So we have a questionnaire-based system where a patient is screened on the basis of either they have cough more than 2 weeks, more than or equal to 2 weeks, there's blood in sputum, chest pain, and things like that. And if patient tests positive on any one of the symptoms, so just to highlight that the screening net is pretty wide. If the patient tests positive on any of these symptoms, they are considered as screening positive or presumptive. A presumptive person undergoes chest X-ray and gene expert. The chest X-ray is then read by a radiologist. A radiologist is a trained radiologist who is not the physician working, practicing in a primary health center, and also the artificial intelligence tool. Then we take radiologist's report, and patient goes for consultation with the physician practicing at the primary health center. After consultation, the patient is either clinically diagnosed of TB, microbiologically diagnosed, or they don't have TB and receive an alternate diagnosis. So I would again like to emphasize on the fact that the people who were screened by the AI solution already had some kind of TB related symptom. So it was not a random screening. So when I talk about the results, I would like you to view the results under the pretext of this condition. So when the chest X-ray was read by radiologist and AI, the AI interpretation was compared to the gene expert results. We use gene expert result as the ground truth and did a sensitivity and specificity analysis to understand the results of the AI tool. As you must have understood that CAD AI solution had no impact on patient's diagnosis, and it was moreover used in a validation study format. And we use Gene Expert as the confirmatory test for people. So coming to the more operational parts, the deployment. We planned a deployment for 3 hours at one site. We had 4 different sites across the program area we were working in. And we hope that on an initial analysis, we hope that we would go into the site and in 3 hours, the software could be deployed and it will start functioning. However, it didn't go that way. And during the program planning process, we assumed that there would be one resource person from the team who would visit the X-ray center, and the manufacturer would be given a remote access to the digital X-ray modality and where they will deploy the solution. So the snapshot on the side is a picture of the X-ray center where one of where the solution was deployed, just to give a brief idea that we were working in a very remote area. This X-ray centers were not very fancy or highly developed, but all the basic necessities of a digital X-ray system were present. These X-ray centers, just to give a background about this, that these X-ray centers are actually private X-ray centers, but in the public health system, sometimes the reporting was delayed, or just to take off that burden, the extra burden we were putting on the public health system, we had contracted 4 different private healthcare units where the patient would be referred from the public health system to go and get an X-ray done. So these were vendors that were contracted by us. After each deployment, that we decided that we would have a testing phase of 2 weeks where we could go back and correct if there was any misstep in the deployment process and see what worked and didn't work, and then move forward with other sites. During the whole process, it took us almost more than 2 months to deploy across all the 4 sites. There were multiple challenges to deployment. Most important being COVID. You must have seen the time period. It was during peak COVID. So there was a lot of uncertainty related to that. And these access centers was pretty crowded, and going there and deploying the software was a bit challenging. There was a small flood issue in one of the centers, and we had to push that. There were also some infrastructural issues with the digital access centers that we were deploying the software in, that I'll talk about in the upcoming slide. So the operational setup was a cloud-based integration that was done in the X-ray centers. Cure deployed a gateway service on the client's modality. This gateway service was used to transfer just X-ray DICOM files to Cure Cloud. Once it was pushed to the cloud, the AI would analyze that X-ray and the report would be available within a few minutes. And this gateway also continuously monitors for new DICOMs to be processed. The one requirement in the digital access center was a DICOM node where this software could be configured. So this was the primary challenge that we encountered. All these X-ray systems that where we were working had a FEESI digital X-ray unit, but the number of DICOM nodes were limited, and the already existing nodes were, there was another cloud-based system functioning on in 3 of the places that we were working with. They had engaged radiologists outside of our program area in bigger cities within India, where they would send the X-rays for reporting purposes. So that node was already being used, and according to the licensing processes, some of the nodes were not free. And even if we deployed then our software system, Cure software system, on the existing node, these centers were not only dedicated to us, they were catering to a crowd much larger than the project area. So if we enabled an auto push facility on these DICOM nodes, then we started receiving X-rays for everyone they were recording. So that was not an ideal condition. So while Cure can integrate an auto push capability in the X-ray software, we could not implement it, and the X-rays had to be manually selected and pushed to the Cure cloud. So the manufacturer suggested that an optimum speed of 8 Mbps would be advised to ensure the smooth functioning of the system. However, we did observe in none of the centers this kind of speed was available, but the operation was but it didn't halt the operations. The setup was still functional at a significantly lower speed, but there were some challenges to it, but still it was functional, and a lower speed can also work. So this is just an infographic showing what the deployment process, the operational setup looked like. So this is a digital access center. This does not, this is a stock image. This does not denote the original access center we were working with. Patient's chest X-ray was recorded, and then it went into the online system that we were working with. And the laptop you see at the top had the internet functioning and everything, and the Cure software was deployed on that. Any technician who was recording the X-ray and then printing it out for the patient also used to select the X-rays that were relevant to the program and send it to the Cure cloud. Once they push that X-ray to Cure cloud, we would receive this kind of image, the fourth image that you see. We would receive that image in our in the web portal that we were using within a few minutes, and we could see if the patient was presumptive of tuberculosis or not. So coming to the threshold score, the threshold score that we used was 0.5. It was pre-decided by the manufacturer. However, after a few months of deployment, we sent over a certain number of X-rays to the manufacturer, and they evaluated the threshold score, but they after evaluation they figured out that 0.5 would be an appropriate score. Looking back, was this the best threshold score to use is still a question that we need to explore. It would depend a lot on the screening algorithm. If you for a program like ours, we don't want to miss any single patient who is there, so a lower threshold score might have been better to use, but it also depends on a lot of other variables, so that would be hard to comment upon. So that would be a bit hard to comment upon, but we still look forward to exploring this and see what would be a good threshold score. Coming to the point of interoperability within the health system. So the public health system that we work with, it doesn't use electronic medical records. So within the scope of this implementation, there was not a question of integrating the software with the existing EMR systems such that the doctors receive those reports. So that was not done. Cure does have its own platform. It's a web-based portal, but that could not be integrated with IS data management system, because we already had a functioning data management system, and we didn't want to. Although the Cure platform had some fields to include clinical findings and CBNAT report, but we ended up not using it because it would lead to duplication of efforts. Although it worked very good within the Digital X-ray Center. So all the data was stored on cloud. The gateway I was talking about was a secure network, so there was data privacy. And also during and after the analysis, all the patient data was de-identified. Even for the search purposes, all the de-identified data was being used. So these are the results. During almost 10 months of the implementation process, we screened 2,700 patients. Out of that, around 58% of the patients were TB presumptive, and around 1,147 patients were assigned to be TB negative by the software. We did a sensitivity and specificity analysis compared with using GeneXpert as the ground truth. We used only this data set comprises of 693 X-rays, not everyone who was screened by the software, and it was done in November 2021, I guess. So when we look at the sensitivity of QXR, it was 75%. It was much better than the sensitivity that we saw by radiologists. That was only 59%. The specificity, however, was better in the case of a radiologist. So if we just want to simplify it and look at the absolute terms of how many TB cases would have been missed by QXR, that was 25% compared to 41 that would be missed by the radiologist. Similarly, the positive predictive value for QXR was around 49%, and the negative predictive value was 70%. When we compared the reports given by radiologists and the QXR system, there was a 71% concordance between both the reports. And again, I would like to highlight that there were some patients who were later on diagnosed clinically by physicians who were practicing. So irrespective of the GeneXpert reports that received, and these results are totally based on kind of a presumptive population that was being screened by the community health workers. Plans for scaling up. We are not scaling up implementation at the moment. We received the funding with our Wave 7 proposal, and you all know that it's a short-term funding. So that also depends on the scale up, also depends on a lot on the further funding that we get. We also hope to dive deeper into the applications of CAD AI system, learn from experiences of other people and countries who are implementing it, and then move forward with further integration into our program. But as a part of the scale up, or the next step, what we are doing is we are conducting an analog film study. We are using a mobile-based application called QTrack, again being developed by Cure.ai. It's a mobile application that converts the chest X-rays to DICOM images once you click the picture by a mobile device. And again, once the picture is clicked, there's the same process. What is there for QXR, that it is read by, pushed to the cloud, read by the software, and the results are available. Although it does say analog film study, but what we are using are films that were printed by the digital X-ray system that I have already showed. We are doing that because analog system is not very commonly used within our setup, but we felt that exploring this would be a good idea moving forward, because since we don't have an EMR system, so sending out the results to patients, to the physicians, doing analysis, getting it in a centralized place, then sending out the results might be a bit tricky. So if a physician in a primary healthcare center is looking at a chest X-ray film and would like some decision support, and then they might prefer using a mobile phone application where they could just scan the film, and that would help them with the diagnosis. So we felt that this could be of a good use within the healthcare system that we were working with, and we went forward with a validation study to assess the accuracy of the analog algorithm compared to the web application we already used. So this is still in process. We are looking at the results and hoping to work on a research paper. The biggest success story was that we were able to screen 2,700 patients. We were able to build the perspective how an AI system will work, where it can be integrated. Also during the pandemic, it was a very important clinical decision support tool when the reporting by radiologist was delayed by a few days, or we had to follow up with some patient. The research study we conducted, it has helped us generate very valuable learnings that we hope would be beneficial for TB programs other than us. X-ray with the vendor was fantastic. We loved working with Cure.ai. They were very supportive and involved throughout the implementation process. Whenever there was an operational challenge, there was a very quick resolution, and we are still collaborating on research findings. The product itself was very easy to use. The web-based portal is very intuitive, and anyone can easily use that. Implementation was a bit challenging because of the kind of area we are working in and the kind of infrastructure we were dealing with. But overall, even the implementation was seamless. Talking about implementation challenges, some of this I have already touched upon. In one of the centers, there was no internet. So we had to collect the X-rays from the center, bring it to our central office and upload it to the system. So that was a bit of a time-taking process. Other than that, the X-ray modalities, X-ray centers we were working with had a very high volume of patients, and selecting so during the deployment process, asking someone to hold off their operations for a few hours and deploy our system was a bit tricky. Also selecting each patient, for example, in each center, if 100 patients from the program went in a particular day, then selecting all those X-rays and pushing to the cloud system. For someone who is not a part of the program, it was a bit tricky to convince the technician to do that. However, it all worked out in the end. And during the deployment process, in some places, we had to call a resource person outside our area outside the area we were working in to support with solving a few IT issues. The lessons learned were, the biggest lessons or the most optimistic lesson that I would say is that we realized that CAD could be a very good passive screening tool. When we integrated the system into a kind of a public digital X-ray modality, and the X-ray started flowing in, we realized that if this is being integrated into the health systems and does a passive screening of everyone who is undergoing a chest X-ray, it could be a good source to passively screen people and reach out and follow up with the ones who test positive. Although we didn't do anything like that, it might be a next good step to try. The second learning was that we were working with 4 different X-ray centers, and all these centers had a very different challenge. So I would suggest anyone who's starting the process is either to start with one machine or one center, and it's better to manage. It is also very crucial to find an appropriate space for CAD solution in the program pathway. It's very important to evaluate whether CAD is something that would replace an ongoing existing algorithm, or it is something that would complement. And if it is complementing a program process, then it might have different applications than something that we have heard about or read about. So exploring that and where it fits and how it can improve a patient's experience is something crucial, and that should be done. And also the threshold score selection, we would have loved to, we should have done a thorough operational search, although the manufacturer did evaluate the threshold scores, but keeping in mind our program requirements and other variables, we should have changed the variables and see how a different threshold score improves the value of CAD system within our program. So a lot of these things that we would do differently next time depends on the lessons learned, such as adjusting the variables, engaging the stakeholders, and evaluating the infrastructure. If you evaluate the infrastructure early on in the process, the deployment would be seamless and it will take less time. And also engaging stakeholders that this is the kind of report and this is how we are planning to implement, and also engaging the number of, if we engage a wide variety of stakeholders, it also helps us understand the best use of CAD system within the existing program. That was all from my side. I'll pause here, and I guess I can take the questions after TB Alert's presentation. Thank you.
Thank you so much, Smriti. Actually, there's one question. There's not a lot. Instead of waiting for the end, I wonder if you can take this. And I also see Dr. Mishra and Dr. Rajeshwari, they're still on the call. And I think this is also relevant to them if they could also answer if they have insight on this to share. So I don't know how long they will stay on the call. This one question is they want to know about the reaction of a local radiologist regarding AI application. I guess this is really about the fear of machine or AI potentially might replace. And I would just also add on to this, and what strategy did you use to mitigate that potential fear of being replaced? I guess it's a question to both speaker, Vizca as well, and our welcome remarks speaker as well.
Yeah, so I think I'll go ahead since we were at the forefront of implementation. So we read about a lot of things, that there's a lot of apprehensions from the radiologist working in the program, but our primary point of contact were primary healthcare physicians who were in the PHCs, and they were pretty excited knowing about the solutions and how the report looks like. And although they knew it for clarity, they knew that we are only implementing this as an operational research setup. So, but they were very excited about looking at the report and knowing about AI. That was something that it had become a buzzword. So there was a lot of interest and not a lot of resistance from physicians. Other than that, the radiologist, one of the radiologists we were working with was in person, and he was very open to learning how the system performs, and even open to see the reports and the difference between the radiologist's finding and AI system finding. He was very open, but we have built a very good relationship with him over the years of program implementation, so that would have been a factor. The other 2 radiologists who were involved in the program were remote, and we were not directly in contact with them, so we would not be able to comment on their reaction. I would give it over to Dr. B.K. Mishra to comment on anything else that he thinks is relevant.
Thank you for very nice presentation. The only thing what I could not understand clearly, the threshold you were talking about, threshold score. So forget about that. You can keep this question. Someone will answer or explain me later on. My comment at this stage is again that artificial intelligence based whatever we are doing. So if some of you who have read the Thoman's tuberculosis, so we used to compare the sputum microscopy and with the X-ray. So we used to say that in X-ray there is intra-observer variation and inter-observation observer variation. And when it comes to sputum microscopy, there is a very strong specificity. But over the period of time, we realized that whenever people have respiratory tuberculosis, there is hardly patient, anyone having the TB of the respiratory system with no X-ray finding. So there is the minimum X-ray damage, X-ray finding, radiological finding. So here we can use the X-ray as a very frequently used screening tool, rather than directing the people who are positive in the questionnaires. Do you have tuberculosis, cough for 2 weeks or more, or loss of weight, or loss of appetite, or night sweating, or fever? So no, if anyone who comes to any hospital for any reason, if I am telling you that if they are subjected to blood sugar testing, if they agree for HIV testing, if they agree to get X-ray done, certainly it will reduce the cost of investing, because CVNet cartridge, it comes about 1,000 rupees under our program conditions. The same way we are using the Molbio TrueNet chips, it is also something about 600 rupees. So we cannot use those rapid molecular test or the line probe assay as such for the screening. But if we do the X-ray, we will be able to detect the earlier cases, and we can confirm using the rapid molecular test. So it will hold, I'm very much optimistic about the use of this AI-based X-ray tools for detecting earlier TB cases. Second, that again, I will come to our own disease prevalence study, that many of the patients, they were unaware of their symptoms, that they are not taking it simply serious thing, that the cough is not serious. They just were self-treating or consulting non-informal healthcare providers. So the result is that in India, the prevalence to notification ratio was more than 2.5, say 2.5. So we are detecting out of the 2.5 cases or 2.84 cases. So we are notifying only one, and we are missing 1.8 cases. If it comes to resource limited setups like us, we are out of 4 cases, we are notifying 1, and we are missing 3. So how can we detect earlier? How can they confirm the diagnosis? How can we put them on the treatment? So the X-ray tool with digital X-ray, with these modern tools of artificial intelligence, will change the game And I'm really very much optimistic. Thank you very much for nice presentation. And I hope that in future, whenever a Stop TB forum informs me, I will make sure that I should attend these webinars, certainly. Thank you, Jinjing.
Thank you so much. For the interest of time, we cannot take more questions at the moment. We'll have a Q&A at the end. Let's move to the next presentation. I noticed there are some questions coming up in the chat. If I could ask Smriti and your team to answer them in the chat as we go. And I see that there are also representatives from Cure.ai on the webinar. They mentioned in the chat. So if you wanted to address some of the questions in the chat as well, please feel free to do so. Without further ado, the next presentation, let's welcome Dr. Vikas. Sorry, he is the CEO of TB Alert. And he has a master's degree in social science and environmental science, and they've been working 17 years in the areas of strategic planning, organization development, and liaison and coordination. Vikas, there you go. You were on mute. Okay, you're muted. Okay.
Thanks, Izan, for that introduction, and thank you very much to Stop TB Partnership for giving this opportunity for us to present it. Thanks to Jacob for giving the machine and exploring our thing, and thanks to Amara and Vishnu who were reviewing our project and giving their valuable inputs. And last but not the least, Zezan and Syed for coordinating with us since last 20 days. So I work for TB Alert India, and our motive is a TB-free India, a future without tuberculosis is something which we look out. And our mission is basically to prevent mortality associated with TB by providing holistic TB care, patient-centric care, addressing the factors which are affecting the TB uptake of the services, as well as hindering the TB elimination as the country is going towards this. And we work in 7 states in India and some of the districts in each of these states. So at present, we work in 8 states in India. This is about us, and our project is called as RAPIN project, which was funded as part of Stop TB TB Reach grant. Wave 6, and also in Scale Up, Wave 6 Scale Up. This project is about roping informal providers for enhancing TB case reduction in Telangana state, India. We have implemented it for 19 TUs in 9 districts across Telangana state, which was scaled up obviously, and this was funded by Stop TB, as already told you. So as part of this project, we had engaged around 1,700 informal providers, and we have screened about, we trained them, asked them to refer people who are having the TB-like symptoms to TB testing, and out of the who are coming to the OP departments. As the experience in India goes, like the informal providers are the key first contacts for the people for any sort of ailment. So that's how we wanted to capture the TB patients over there. And outpatient department clients of these 1,700 providers were screened around 3.96 million. And out of that, 28,000 people were referred for testing. Out of that, 28,037 have undergone TB testing, and around 3,574 were bacteriologically confirmed, and all forms confirmed TB patients were around 4,962. We were around 29% ahead of the planned targets, and in terms of bacteriological positive, and 68% against the all forms. So about the project, I just wanted to give a small glimpse. We have developed a mobile application for the project, which was installed in the mobile phones, Android mobile phones of the informal providers. And these were the small information which they have to punch in when punch in when a person having the TB-like symptoms come them, visit their OP. Informal providers enter the details of PTS in the application. And then from the application, it gets into the message goes to the project staff initially when they were doing the project staff, so that they did the follow-up and got the patient for testing. And now it's been going, after we phased out, we have made the NTP officials as part of it, the local NTP officials who can follow them up and get them tested as such. So this is all the project framework is. So now I get into the actual experience of using X-ray, Fujifilm, X-ray film. These were some of the questions which we used to get when we asked people to get for tested. And most of this are related to the wage loss, or they don't want to spend the money for traveling for testing. They were asking whether it can be done at the nearby place. And some people have said, there's one thing, I went there, but the clinic was closed. So all these things are the direct responses which came from the people when we asked them to get tested for TB. So this is how we thought of having a sort of various innovations over there. And among them, using a portable handheld X-ray machine was one interesting pilot initiative which we did. And this was approved in January 2021, and we started using the services in August 2021. Meanwhile, there was a lot of gap. This has took off. We did a doorstep sputum collection and transportation in the project to address some of the issues which I mentioned over there. Another activity which took was like Sampak Data. We carried people in autos, people having TB-like symptoms or whose sputum microscopy was coming negative, to the nearby X-ray facility to get them tested to complete the NTP algorithm as well. And we also established a call center services where people can call in and clear their doubts. And if they were having any symptoms related to TB, they were catered through all the above three sort of services. Yeah, this is how the overall X-ray machine was bought out. We got the approval to buy it in 2021, and we placed it order January 2021. We placed the order in February 2021. We received the machine in April 2021. And the Atomic Energy Regulatory Board is the authority which has to approve this usage of this machine. So which we got it in June 2021. And apart from that, we had to purchase a device which measures the radiation thing, which we call test TDL device. We were not aware of that. So probably it took another month. So by the whole process is completed, we used this machine from mid of August, and our grant ended on December 2021. So it's hardly the data which we'll be presenting would be for 4 months approximately. So these are the components of the Fujifilm which we got, which we purchased. This is the X-ray portable X-ray unit. This is a panel. These are some of the wires for USB accesses, and this is a high-end computer module, which console which we used, and this is a tripod where the machine needs to put, and these are some of the other accessories to be used. Not only this, we also have another stand like this where we have to fix it to the panel to this, and this stand is very important stand given the fact that it holds the panel, flat sensor panel, and which is quite expensive sort of setup. So for the proper planning of the engagement, this was a community-based setup which we did. This community level screening camps which we did, and all the camps which we did, the work and the processes evolved over time. We started with something, we incorporated the learnings and moved forward. I have culminated the overall thing. First, about the important stakeholder, of course, is the National TB program, to orient them, tell their advantages and the value addition to it. Then to look into the informal providers and sensitize them about this machine and requesting them, the PTCs coming there to their clinic, to the camp, so that they get benefited out of this. Then we have staff who needs to be trained on the machine, which is a set of some 10 to 12 small equipments which needs to be maintained clearly, and we need to train them on reporting and recording aspects. There's also again the frontline workers like ASHA workers and Anganwadi workers, ANMs, local ANMs, whom we had to involve in this process, because they know about the community there, they know about the vulnerability where the vulnerability for TB is present, and also they are very helpful in the whole process of conducting this camp. Another one is the local politicians. Obviously, we were doing it as a community setup where we had to get a place to place the machine to conduct the whole setup, and also to see that everything runs smoothly. And the local health officials like the PHC officials and the ANMs over there to come and help us in the overall camp as such. And finally, the local community structures like the key opinion leaders in the villages, the women's self-help groups and other people to mobilize or to propagate about the camp so that the turnover will be good for the camp which comes in. So with respect to the program planning too, there was no clear, we did not have any customs clearance issues, because we have opted for Fujifilm portable X-ray, and we got it, and the vendor delivered it directly to us. The other part was like Atomic Research Regulatory Board approval has taken a long time. I should say it has taken around 3 to 4 months approximately. And this was facilitated by the Fujifilm executives itself. We did not have to run around the board to get it approved, and they were quite kind enough to do whole of this work for us. This verification of the machine was done in 2 parts because this was the first machine in India which was imported, and they wanted to reconfirm and recheck how it is all working. And this was done virtually because it was done during the COVID second wave time. As I was telling, thermoluminescent dosimeter TLD device, which needs to be put on to the while using person using the X-ray thing needs to be done, which needs to be procured separately after getting the AARB approval. So as I was telling, it has taken a quite 4 sweet months of our time in getting onto the field, but it was a required mandatory. So further procurements might have been quite easy going by this process altogether. So the first one is like where we were doing these camps. As I was telling, the screening camps were organized at the community settings in the villages, at the local administration office, or a school or a government health facility was used for that. And why these sites, how the sites were selected was of more of an TB vulnerable population sites like industrial areas, slum areas, and sometimes in some specific homes like old age homes or one orphan homes we did conduct it. And the second priority we took was like to catchment areas of 2 or 3 informal providers because they were the key stakeholders of this project. We wanted to ensure like their clientele get good benefit from this. So 2 or 3 informal healthcare providers catchment areas were selected, and a center point was selected to conduct these camps. And the sites were are the informal or the TUs or the blocks or TUs where the referrals from the informal providers are more, and the people who have gone to the testing to the NTP clinics were less. So that sort of areas were also selected to conduct these X-ray camps. with respect to the trainings, Fujifilm executives gave us extensive training. They trained 4 master trainers of us, and these 4 master trainers further trained 10 other local field staff. But we have ensured, like during all these processes of X-rays, a trained radio technician is present to this with the camp, so that because the machine was costlier machine and we wanted to be on a safer side. So as I was telling, this training included of how to handle the machine, safe handling of the machine, setting up of the system, operating of the machine, handling of the computer console, which is a very ultra modern sensitive system, and safe packing also. So that's covered it, and as we were doing it as a community setup, we wanted more of our staff to be understand and well versed with the operations of the machine. So we have trained 10 of our local field staff to in handling of this machine. So as a vendor selection, we wantedly asked for Fujifilm things. So there was no other thought of going with other providers. And the cost of the machine, along with all those parts, was something around $51,345. Initially, we did not take the AI for this machine, thinking like it would be a costly affair. So, but after implementing for a few days, we understood like it is taking a longer time and the purpose was not being solved. So we have opted for the software, external image processing software, which was procured from Fujifilms as well, and it costed us around $22,000. And machine came with 1 year warranty from the company. We are in the process of renewing the warranty, yet to get the warranty cost from the vendor. And additionally, we have taken, since this was being traveling from one village to other village, from one district to other district. So we thought of having a precautionary accidental and theft insurance, which we had to take, and it costed us something around $602. And other machines, other accessories such as dosimeter, a lead apron, and the extension boxes, something cost us around 9,000 rupees. So the lead apron is something which we have specifically bought in and asked the person operating the X-ray to wear it while taking up the X-ray. So this is how the setup works. This is the distance and other things which we keep in. This is how the registration and other things happen at the camp. And this is how the crowd management is done, where one by one is sent into the X-ray machine. And also the distances and the setup which is required. This is required to take up the, to screen the X-ray altogether. So this is how the setup looks in by organizing it in the field. First is a screening algorithm. First, the people would be in the waiting area or in queue. There, the outreach workers and the stakeholders were talking about the TB and generally starting with health and generally slowly getting into TB and giving awareness about TB. Next, there was registration, where the demographics, any comorbidities, weight information, and hypertension related information was checked up. This was done by either the project staff or the healthcare staff. And then the screening was done. This is an oral screening where if the doctor is present, some camps we had a doctor, some camps we managed with the auxiliary midwife, ANMs who are present over there. So they used to get into their room and start telling about the problems, and then they used to introduce the concept of how why this camp is being done, and the X-ray would be taken sort of information to them. Then the X-ray screening was done. There are 2 or 3 situations where a person undergoes for the X-ray. If the medical officer of the chest X-ray, he is a general physician, we have relied them on very much on taking this. If he is present, he reads the X-rays on the screen itself, and and the people with lesions or suggestive of TB were separated for counseling. In case if they were not, if the person was not there, MO was not there, we had to collect all those X-ray setups and we had to mail it to a radiologist or the medical officer for screening. So there was some time gap over here, which had caused in because of this thing, this not availability of AI. Then it's the preparing for the tests. Once the people who are found suggestive of TB in the X-ray, they were counseled about TB and they were asked to go for confirmatory tests at the NTEP as per the NTEP guidelines. We strictly believed in the NTEP guidelines. If the X-ray is not read and we have to send it to a radiologist, then after getting the result, the field staff has to go back to that particular village, follow up those patients and counsel them to go for testing. So again, there was a time gap which was coming over there. And this is how we thought of buying the artificial intelligence thing, AI thing, so that a lot of time gap could be saved and only the confirmatory X-rays can be sent it across to the radiologists or the medical officers to read. So after implementing it for some 3-4 months, we realized 3 months or 3.5 months, we realized that it is taking time and we need to ban AI, and thanks to Stop TB for agreeing and giving us the opportunity to buy it. And after that, after this process of preparing for them tests, they are sent to the NTP office and clinics where they undergo as per the NTP algorithm. Once they reach the NTEP, this is an algorithm where they undergo the TrueNAT testing or CBNAT testing, and then if MTB is detected over them, they are confirmed bacteriologically and the treatment initiated. MTB is not detected and no symptoms are there, they are informed about, they are asked to come back after 15 months or to refer to the general department and other departments. But if the symptoms are persistent, then they go back to the MO and he clinically evaluates them and then put on the treatment. This is as per the algorithm of NTEP, which we try to put it in a nutshell for you. So the operational setups, the screening was done in the X-ray setup. A proper electricity with wiring is required, so that we have to be very specific about checking about the wiring and other things, because the machine is used for a longer time over there. A room with approximate 6 feet distance between the panel and X-ray machine, we ensure that it is followed. And with avoiding crowd is good, but in practical situations, it might not be possible, but we try to avoid as much as, because people don't come into the X-ray room and stand and visit seeing them. So we maintain that. And as I was telling, the person operating the X-ray camera was asked to wear a lead apron. And he also had to put in a TDL device, which we had to send it back to AARB for every 3 months to measure the radiation. Of course, while we purchasing it, and we were told like the radiation is quite very, very less sort of thing. And the setup, because it has got a very complicated box and all the things with it, and finding out, putting up together is something which we initially found a bit complicated, because it is a new machine, a costly machine. How to handle it was a major concern. But after doing the first 2 or 3 camps, then our staff got used to this. And it was quite interesting. X-rays done under the supervision of an X-ray technician was done, and CAD was attached. As I was telling, we purchased it later towards the end, and it was attached to an external cord. So this is how the X-ray looked like when we take it from the machine, and this is the excellent quality of the X-ray was impressed one of the radiologists whom we used to send these X-rays for his reading. So these are the numbers. As I was saying, these numbers are from mid-August to end of December. Total in 53 camps, we had done around 3,312 screenings. Out of this, 4,822 were suggestive of TB, which is 15% of the screen. among the found suggestive people, 367 people have undergone CBNAT testing, which is around 76% of the found suggestive for TB. And among them, 85 people were found bacteriologically confirmed, which is around 23% of the people who have undergone testing. And total, altogether, all founds included 146, where 61 were clinically confirmed and 81 were bacteriologically confirmed. Altogether, among the people who have undergone screening, around 30% of the people were diagnosed with TB, either bacteriologically or clinically. So data was entered because we did not had any interportability or linking of thing, because these patients or the PTS were registered in the as part of the program, NTEP program. So NTEP has got in India has gotten a portal called NextShare portal, where the data was entered by the NTEP staff. They were initially, while from the testing to while allocating ID for the patient after identifying with TB. So everything was done in NextShare, and if this was done by the NTP local level officials itself. We had nothing to do in that sense. And this is how we have, this is the information where we did with the X-ray after purchasing of the AI. So after our project as well, we did an 8 to 10 camps after the project is finished off, because it's a cost intensive processes where we had to have a vehicle and all those things. We could manage with 10. So we have screened 635. Around 25% of the screen was suggestive of TB, and all were undergone CBNAT testing. This is how the you can see the difference over here. When we use the AI, we could immediately separate the cases over there, people over there, and counsel them and put them on, suggest them for TB testing, CBNAT testing. Out of this, 35% of the people were found bacteriologically positive. So this is where the major important role played by AI, where in the previous slide you have seen there is a 25% loss of patients when we took the X-ray, and then we go back and counsel them and get back onto the system. So here the complete people were PTS, people having TB-like symptoms were tested, and they have undergone the CBNAT testing as well. So this is how the information is. The data storage, the computer and everything the information was stored in the console, which is a logged and protected one, and having access to the only program manager. After each and every camp, we used to take data backup in a hard drive to protect it, because we were not much used to the cloud utilization and other things with the X-ray. With the AI thing, so we didn't. And while sending the reports to the radiologist, personal identifications were de-identified. This is one of a success story, in the sense the whole exercise of doing a community screening camp is a successful and a learning exercise for us. But this is an information from one of the TB patients who got benefited from the X-ray machine. He belongs to, a lot of my time was saved. I don't get much leaves in my factory. I went to X-ray camp in the morning before going to the factory. They helped me get tested at the government center next day, and treatment was started within 2 days. I could manage with only 1 leave. So that's how the machine has helped us in identifying these vulnerable populations who are industrial workers and not able to spare time because of the wage loss and other things. That's a very excellent thing which we had to do. The experience was Fujifilm Fuji team was very excellent. They supported us during the procurement process while training, and on-ground support is also very excellent. Even today, if we have any issue, they do come down to us and explain us. But we lost a lot of the time with the AARB approvals. And of course, we bought the Cure AI from the vendor Fujifilm itself, and we used to our notice itself. We did not have much interaction with the QARI team. So we are just planning to establish that going forward. So coming to the challenges part, the fully charged camera used to give only 40 images. and our turnover was around 60 patients or more than 60 patients. So after 40 images, we can't take take the machine to screen it. So we had to charge it for 10 minutes to take one X-ray. So that's how it is. The impatience of the restlessness of the people who have come up to get the tested was something which we faced, but we had to manage it. Being it a community level intervention, these sort of challenges are quite common. And machine had two big stands which needs to be managed, and a box which contains, for the protection of the equipment, a big box as of a suitcase which we travel it. So this is not handy for one person to handle. So we need two persons to handle it, and also we require a four-wheeler to transport it from one village to other on the safety perspective as well. So there was some AIs inbuilt, and most of the NTP officials recommended for an extant opinion from the radiologists. And these are some of the learnings. I'm coming towards the end of my presentation. So the preparatory work, keeping in AARB approvals, I understand that even for every machine which is purchased, this has to be done. So preparatory work needs to be done on this perspective. One has to ensure proper logistics, like a vehicle to carry the machine to the field, a trained LT or the trained staff and functionary who is understanding the functionality of the machine is something which we need to keep in mind. Coordination with frontline health staff is desperate, as they know the vulnerable and hard to reach community and mobilize them. Engaging all the community structures, local leaders, informal providers is important for proper mobilization of the camp, for the camp to make it a success. And this whole setup of community screening is not an one-day exercise where we go and do the X-ray and come back. It is a process where pre-training and pre-camp and post-camp work is done, and we need to keep in mind of all those requirements where the staff needs to plan it accordingly and coordinate it. Proper handling of training of staff on handling the machine is very, very important. A lot of care needs to be taken, as machine is being costly and the information is very sensitive. A proper orientation and consultation with respect to the machine AI needs to be given to the officials in order to buy in the requirement of this particular interventions. And I come to my end of my slide. Thank you very much.
Thank you so much. We don't have a lot of time left for the webinar, but there are a lot of questions remaining. If I could just highlight a few more, and any participant who are willing and able to stay longer, let's try to stay a few more minutes longer. If we cannot address all the questions, we will collect the question from the chat and send it to the speaker. But I already see a series of questions. Mostly I know that they're from colleagues from Kenya around the radiation safety concern, around the use of X-ray, the Fujifilm X-ray. So if I could ask either Brenda, Lorraine, or Lydia to unmute yourself, and based on what you just heard now, if you could ask your question here live, and Vikas is here to answer. And the Fujifilm colleague from Fujifilm, there are several of them are also on the call. So feel free to also answer these questions from Kenya and other partners.
Okay, good afternoon. Can you hear me?
Yes.
All right. So thank you very much. I mean, I think very good presentations and very good work ongoing in India. So I think the questions we had were around, maybe because Kenya is at that point, were around a lot of radiation safety issues. So just, I think one of the questions that I had is that, did you assess the machines in country in terms of actual radiation measurements, and would that report be available? Secondly, thank you for alerting about the dosimeter. We also realized that when the machines came in, but we've now gotten those. I think my colleague had also asked about the number of x-rays that it can do per day. I think you've alluded to that, about 40, you were able to do about 40 after charging, so you can say something about that. We are happy to see the quality of the images. Yeah, so maybe mostly about the radiation safety and whether now what was the reading, the 3-month reading, and for maybe a radiographer, for example.
So Vikas, if you could answer this first, and any colleague from Fujifilm on the call, if you can also add if you have any remark to add on top.
Yeah, with respect to the quality of the machine, quality of the X-ray, as I told, it's very crystal clear, and we can easily, and when even the QAI was installed, also we could easily find it. So the quality related matter is something which we not have to doubt about. It is very clear quality of the X-ray. And second one, I saw someone asking about the radiation things. Because if because this becomes very important for us also to do, because this is being done at a community level setups. So we have ensured, I'm not getting the radiation thing, my friends from Fujifilm can add up, the 0.0026 sort of radiation thing, something which came up. So it is highly safety. And secondly, like, we ensured the person who is using the operating the X-ray, where, and because we allowed only one person, the operator, and the patient was there in the room. So he was ensured to, we ensured like he put in the lead apron at any point of time he was taking the X-ray. Another point about the space and the distance, like, because this is being done at a community setup, and it's often difficult to get a vast rooms and good big rooms. So we ensured, as I was telling, is like even the room at least minimum has a distance of 6 to 7 feet from the X-ray to the patient to the panel, so that the so that the treatment, it can be qualitatively clicked across. So this is the minimum requirement which checked in, whether if 6 to 7 feet distance between the X-ray and patient is there, and no one comes into the room crowded, so that everyone would be safe on that front. So these are some of questions which I picked it out. Of course, there was some question about increasing the changing or the new thing, new film, but we bought it last year, and the machine is supporting us for us within 40 screens as of now. And after purchasing the AI, it became quite easy for us to do the separation as well, so something like that. Thank you.
Can you quickly clarify which AI did you use? That Cure AI, because that's
Yes,
also a question.
right.
Okay, great. I see Daisuke-san from Fujifilm mentioned that the improved model, and that's indeed true, because the innovator in health and the TB alert, they were using the older model because there was a pilot, they were first to start. And then a newer version, which is applies to GDF, has an improved model that the X-ray can be charged longer and can take, with the battery, can take more than 100 exposure. Any other remark you wanted to add, Suki-san?
Thank you, Ms. Ginger, and thank you very much. This is Fuji from Tokyo. So about the battery, so what we provide to TB Alert is the first generation, and then we also got the feedback of the the battery power, and then we work hard with our team to improve the battery issue. And then right now with the XR, we can take around 100 images, and then we can also provide the the external power bank So you can also connect the power bank during the exposure. So the maximum you can take around the 300 the cases per day. So which we think like it's quite enough for the 1-day screening. So we will also provide the improved model for the TB alert to get the your evaluation. Thank you very much.
Thank you very much.
Thank you very much. And I see Dr. Austin from Nigeria, the New Tools Project coordinator, is on the call. If I could give him the floor to talk, to ask his question, because Nigeria is also at the point with a lot of concern. So Dr. Austin, if you're still on the line, please go ahead.
Thanks, Jijen, and thanks to all the presenters from India. Very, very illuminating experience you shared there. I was more interested in the equipment use in the field and what the experience has been with faults around the use of the equipment. So did any of the pilots experience faults while using the equipment on any of the components? And if yes, what were the commonest equipment faults that were reported while using the Fiji? Over, thank you.
Thanks, Austin, for this question. We did not find any problem with the equipment and no faults were there. It was only, we did not find any faults with the equipment at all during our altogether 70 screening camps which we did. It worked very well. The only, as I was telling about the battery thing, was something which we had to think about, and we also took that utmost care in maintaining and handling the machine as well. So we did not find any fault with the equipment. Thank you.
Thank you very much. And then now I'm going to take on some question from the chat, which is the next one is about clinical diagnosis rate at 41%. How is that compared to the national data? And would, in your opinion, if it's higher, would the use of X-ray lead to a higher rate of clinical diagnosis?
We did not analyze it at the till that extent. So we are just gathering. We wanted to do some more camps in that front and then do that analysis to comparison and how does it affect. So as of now, we haven't done that comparison. Thank you.
Okay, maybe just as a follow-up, as clinical diagnosis increases in clinical diagnosis with the use of X-ray is a big concern. Maybe as a follow-up to clarify, were there any changes in behavior because of use of AI, that X-ray results are just being used as a clinical, as a final diagnosis instead of just for screening and triage?
That's depends. I feel that depends upon the local settings how that will be taken up. Here, the NTP officials were quite supportive, and after doing the bacteriologically confirmation tests, they were also ready to check up and do the clinical evaluations as well, so that patient doesn't miss out on the treatment related aspects. So I did not find any, we did not find any such sort of behavior changes or something like that. Thank you.
Thank you. And anyone else who would like to ask the question live, you can raise your hand. We'll monitor the chat and the hand. In the meantime, I think there's a lot of question around children under 15. What's your experience of taking X-ray and also using AI, if you're even using it for children under 15s?
So another learning is to be taken up into consideration over here is like the time of the camp when we conduct. So while doing these camps, we did not we were not able to analyze what sort of patients would be, what sort of PTS would be coming for testing and sort of thing. But our major load was people were in the age group of 30 to 26 to 30 or 60 to above 60 people were coming in. So the placing and the timing of the X-ray is also an important learning, where I need to check back and I can confirm it on the chat, check it from the chat and confirm how many of the people whom we screened were below 15 years. But at this point of time, predominantly, I feel that most of the people were adult group which had come into the come onto the X-ray camp, because, and that's why I'm saying the time and the date, time and the day and the date are also very important to conduct these camps, to see that a large variety of age group people do come into the X-ray camp. I'll check the data and I'll get back regarding to the 15 years and other things. Thank you.
Great, thank you. Is there any other remarks or question from the audience? We will be collecting the answer as Vikas mentioned, the breakdown. We will be sending this out to everyone participated today. Now, just before we break, and thanks so much for joining the webinar today and stay on. It's a long webinar and we definitely learned a lot from the two projects. As a reminder, Shihab had just sent the feedback form in the chat. It's a short feedback form. If you could, if you have any feedback for us to improve, what else you wanted to hear from us in the future webinar, please let us know through this feedback form. I will also be circulating the, I'll keep the chat on for a bit longer. So if whoever wanted to ask question and haven't had the opportunity to formulate before, you can still send it in the chat and we'll collect this and send it to the speaker. In a few days, we'll post the recording and the list of question and answer all on our StopTB website. With that being said, if there's no other further question and remark, we can adjourn today and stay tuned for the next webinar. Thank you so much for all the speakers.
Thank you very much, Lisa. Thanks. Bye.
Thank you.
Thank you. Thank you. Thank you very much.
Thank you, Syed. Bye.
Thank you very
Thank
much.
you.
उसमें ना बुक वैल्यू का confusion